course. I would also like to acknowledge that I do not have any financial interest in any of the products mentioned in my presentation. Yes, as ma'am already said, the keratoplasty has seen growing in leaps and bounds from what started as penetrating to a lamellar, and now it's totally a customized component corneal surgery. And if you just read the textbook of Jacobi, it says that lamellar keratoplasty was once considered as a very difficult surgery. But now, with good microsurgical techniques available and good better instrumentation, the lamellar keratoplasty, there's a renewed interest and people are going for this kind of a procedure. With regard to the types of the procedures, the anterior lamella can be classified as just a superficial or an anterior or deep anterior lamellar keratoplasty, and the endothelial keratoplasties can be either a manual or an automated DSEK and a DMEK. This is a descemet membrane endothelial keratoplasty. With regard to my presentation, I would like to go ahead with the instruments being used in first a manual procedure, then an automated anterior procedure, in a DALK, then a DSEK or a DSAEK, and finally, how about the instruments used in DMEK. Coming to the manual lamellar keratoplasty, much of us will be using the suction trephines, and of that, the Hesburgh-Baron suction trephine is the prototype system. This is basically used for the host corneal trephination. It has a spring-loaded disposable syringe, and this creates the required negative pressure, and the suction fixation provides the stability on the globe. There's an outer corneal suction ring for the fixation to the cornea, and there's an inner circular cutting blade. The newer model has a crosshair for an improved centration on the cornea, the host cornea. They are available in sizes from 6 to 9 mm with 0.5 increments as well as a 7.75 mm trephine available. With each 90 degrees turn in the crosshair, the cutting blade is lowered by 60 microns, and thus we can go to the depth that we need. Then coming to the various lamellar dissectors that are being used in a manual lamellar keratoplasty, generally the instruments should be, they should be lightweight, they should have a fine edge, they should have a good handle for firm grip, and the curve should be conforming to the corneal curvature. The various instruments that are used for the lamellar dissection in the cornea are crescent knife, there's a guarded diamond knife, Took's knife, Porfik's knife, Desmar's lamellar dissector, and Gill's lamellar dissector. The first one on the left side is a guarded diamond knife. As we all know, it has a foot plate that can control the depth of the blade that is being extended beyond the foot plate. The adjustable blade depths with gross micrometer, there's a micrometer with a gross micrometer. With that, we can adjust the depth of the blade. One division on the scale is 10 microns, and one full revolution of the barrel gives 500 microns. The Took's knife is again used to create a pocket for the initiation of the lamellar dissection. Porfik's knife has a double-edged blade. It helps in outlining the graft as well as in dissecting the lamellar planes. Crescent knife is the most commonly used and the cheap instrument available for lamellar dissection. It creates sharp dissection. Desmar's lamellar dissector, it is used for the open type of dissection. It has a curve in the vertical meridian. It is used to sweep the fibers in cutting and in teasing motion. The Gill's lamellar dissector is available either in a straight or curved blade. Coming to the automated lamellar keratoplasty, the most important equipment that has been designed and that has almost changed the landmark of lamellar keratoplasty is the availability of this Moria microkeratome with the turbine-driven and the motor console. This system is used in conjunction with the artificial chamber system, and there are multiple microkeratome heads available ranging from 130 to 400 microns. And recently for ultra-thin D6, we also have microkeratome heads available from 50 microns. The artificial chamber system that is being used is a stainless steel structure with the 3 screw-type safety rings. The first base is mainly to position the sclera on the top of this base. Over that, we have a metallic ring to keep the sclera held fixed. And over that, there's a track through which the microkeratome passes through. For the recipient bed preparation using the automated microkeratome, we need to use a suction ring to stabilize the globe. The suction ring determines the size of the lenticule that is obtained on the host bed. The sizes of the ring that are available is from +2, +1, 0, and -1, and correspondingly produces a smaller to a larger diameter host cut. Next, coming to the specific instruments that are being employed in a DLK procedure. As we all know, Gerrit Mellis was the first person to have started this technique, and in his technique he had used multiple spatula. Accordingly, he had colored them as red spatula, white and blue, and each for a specific purpose. The red spatula is a short triangle instrument to dissect downward till the desired depth at the starting of the procedure. Then the white spatula is a half-length curved spatula. It was mainly to dissect up to 2/3 of the cornea. And the blue spatula is a full-length curved spatula to complete the dissection across. In the recent technique with the development of the Anwar's big bubble technique, the trend has shifted towards the big bubble technique of DLK, and many cannulas have been devised for the air injection and to get into the appropriate plane that we need. From India, we have the Foglas cannula, there is Sanicula's cannula, and many other cannulas for this air injection. The basic principle and the basic structure of these cannula is that they have a blunt tip so that it can avoid perforation, and the port is towards the bottom side, and it is very thin 27 gauge, so that when we inject the air, it just directly goes into the plane where we need the big bubble to be formed. Coming to the specific instruments employed in endothelial keratoplasty. With regard to the donor preparation, it can be either a manual technique, which is called as a DSEK, or more commonly performed and more precise and finer one, that is the DSAEK, wherein we employ the automated microkeratome. In the recent past, there's a greater surge of interest in ultra-thin grafts because it's been found that thinner the graft, better is the visual outcome. And so this Moria has again come up with the set of microkeratome heads ranging from 50 micron to 300 micron, a separate disposable artificial chamber system, and special inflation tubing and syringe sets to maintain good pressure throughout the procedure. And depending upon, so in this ultra-thin technique, two separate cuts are made. First is a debulking cut, followed by a refining cut. And depending upon the thickness of the second lamella, the second microkeratome head is used. Femtosecond laser is also being employed for the donor dissection in DSEK lenticules. But as well known, microkeratome interface is much more smoother than an interface produced using a femtosecond laser. And of course, it's a very expensive option which everyone cannot afford. Excuse me. With regard to the instruments employed in the recipient preparation, there's a DSEK marker which is of either 8 mm or 9 mm used to place on the host cornea for the internal scoring. The size depends upon the surgeon's preference as well as the corneal diameter. And there's a reverse Sinskey hook which is used for the scoring of the Descemet membrane. This is the most commonly and most easily available instrument for scoring. There are other scoring instruments available such as a Steinert Descemet stripper. There are scraping instruments available to scrape off the Descemets that is being scored, such as Terry Descemet scraper, Dias Descemet scraper, Melis, and even stripping forceps to hold the edge of the Descemet and then scrape them and pull them out. Various graft insertion techniques in DSEKs, and accordingly we have many other instruments available for inserting the graft into the anterior chamber. The oldest techniques were using the forceps, and then we have the pull-through technique, and recently what we commonly employ is the glides, the Busin glide and the tan endo glide. And the newer ones which are still being evolved is the injector systems. The forceps, the special forceps that is being used for a DSEK graft insertion is a single point fixation one, which is a non-compressing forceps to grasp the taco or the folded graft. The Busin endothelial glide is the most commonly used one. Previously it was available in a 5 mm diameter opening, now it is available in 3.2, so that we can even do it through a smaller incision. This is used alongside a Busin forceps. This is a bimanual pull-through technique. The tan endoglide has been devised by Dr. Donald Tan from Singapore. In this, the graft has a double coiling within the cartridge system, and so there is no touch of the graft at the wound edges, and the AC remains stable throughout the process of donor insertion into the anterior chamber. So this is the introducer with the glide cartridge, and they have the endoglides available for a normal DSEK thickness of the donor thickness of 130 to 250, another for a thinner donors, and there is also a support platform available on which we can keep and load the graft. This comes along with the loading forceps and a placement forceps to pull in the graft into the AC. The injection devices that are still being developed are the nuclear corneal inserter, the endocerter, endoshield. Coming to the specific instruments for DMEC, yes, again we'll have for the preparation of the donor, the Descemet membrane, a scoring device like a reverse Sinskey can be used. To lift up the membrane, a non-tooth forceps to just lift up the membrane, and can be inserted using an IOL cartridge. Thank you. Thank you for your patient hearing.